Good evening, all. I welcome you all on behalf of Ophthalmological Society of West Bengal to this Retina Masterclass webinar. We are grateful to the masters of this evening who doesn't need any introduction. In fact, they are the stalwarts in their own capacity in their respective field. We have with us Dr. Giridhar from Giridhar Eye Institute from Cochin, and Dr. Muna Vende from Shankar Netra, Chennai. Today we will be discussing about two very common medical retinal disorders like AMD and DME, and we look forward to have some practical guidelines so that we can manage our patient in a better way. Before we start our academic program, I would request Dr. Shubhashish Nag, our Honorary Secretary, to make his opening remark. Dr. Nag, please.
Thank you, Dr. Aniruddha Maiti. He is the Chairman Scientific Committee of Ophthalmological Society of West Bengal. Hi, everyone, and good evening to our speakers and panelists, and hello to the attendees, those who have logged into YouTube and Facebook, where we are live today for the webinar, a masterclass on retina. On behalf of all members of OSWB, I convey our highest regards and gratitude to the guest speakers tonight for accepting our invitation despite their very busy schedules. Thank you, Dr. Muna, and thank you, Dr. Giridhar. Today, our members are eager to learn from you, the masters, what we ought to know in a nutshell about the trends in two very common but relevant subjects in retina, and I'm sure each of us will go home enriched. I also welcome our panelists and moderators who will definitely make a difference to the discourse. Thank you everyone once again. With these words, I request OSWB President, Madam Dr. Pushpita Sahu, to preside over this meeting. Over to you.
Thank you, Shubhashish. Good evening and welcome everybody to this Retina Masterclass webinar of OSWB. We are very, it says, an evening with the masters. Now, we are very fortunate to have with us today two erudite speakers, Dr. Giridhar Anantharaman and Dr. Muna Vende. Dr. Giridhar is going to speak on approach to wet AMD, ARMD, and Dr. Muna is going to speak on management of diabetic macular edema. Both are extremely relevant topics. All of us have patients coming from both the categories, and I'm sure after their talks, our knowledge will be enhanced and will be enriched. I take this opportunity to thank the chairpersons, Dr. Kajal Prasad Ghosh and Professor Ashim Ghosh, the panelists, Dr. Saurabh Sinha, Professor Shambhuddha Ghosh, Dr. Devdulal Chakraborty, Dr. Siddhartha Ghosh, Dr. Abhijit Chatterjee, and Dr. Sudipto Das. The moderators, Dr. Rupak Roy, Dr. Sangeeta Roy, Dr. Vedang Shah. The coordinators, Dr. Kumar Saurabh and Dr. Devmalo Das, and convener, Dr. Aniruddha Maiti. I also thank Allergan, who has been beside us for this webinar, and the viewers who have logged in from other platforms. Let's not waste any more time. Over to Vedang to take the web forward. Thank you.
Thank you, Madam, and thank you, OSWB and Dr. Maiti. We have with us a very prominent and senior ophthalmologists from West Bengal. So let me first introduce to you the chairpersons for the program tonight. We have with us Professor Ashim Ghosh. Professor Ashim Ghosh is the chief of the vitreoretinal unit and the director of the Regional Institute of Ophthalmology, Kolkata. He has been a teacher for last 20 years, and sir is also an state ophthalmic advisor under the Department of Health and Family Welfare for the government of West Bengal. We have with us Dr. Kajal Prasad Ghosh. Sir is a very senior ophthalmologist and a medical director of the Nemesis Eye Center. Dr. Ghosh is currently the president-elect of the West Bengal Society of Ophthalmology. We are proud to present to you a galaxy of our own stars as panelists. We have with us Dr. Saurav Sinha, who is the senior consultant at the BBI Foundation, Kolkata. Dr. Sinha was the medical director and the chief at the Shankar Nethralaya, Kolkata. An eminent VR surgeon, Dr. Sinha also takes special interest in teaching. Dr. Professor Sambuddha Ghosh is the senior ophthalmologist and the professor and HOD at the Calcutta National Medical College. Dr. Rupa Kanti Biswas is the senior consultant at the BBI Foundation, Kolkata. Sir is also an executive member of the OSWB and the chairman of the PG Education Wing, OSWB. He is also an ex-consultant at the Shankar Nethralaya, Kolkata. Next, we have Dr. Devdulal Chakraborty. Sir is a senior consultant at the Disha Eye Hospitals, Kolkata. As Sir has done his fellowship in vitreoretina from the Shankar Nethralaya, and he has a number of publications in the peer-reviewed journals. Dr. Siddhartha Ghosh is the consultant ophthalmologist at the GD Diabetic Multispeciality Hospital and the Apollo Hospitals, Kolkata. Dr. Ghosh is also the treasurer of OSWB. Dr. Abhijit Chatterjee has obtained his vitreoretinal training from the Arvind Eye Hospitals. Dr. Abhijit was also trained in the pediatric retina surgery from the LV Prasad Hospital, Hyderabad. Currently, Dr. Abhijit is the chief of vitreoretinal unit of the Priyamada Birla Arvind Eye Hospitals. Last but not the least, we have Dr. Shudipto Dash. Sir is a senior consultant in the vitreoretinal department and the academic in charge at the Shankar Nethralaya, Kolkata. He has contributed in several book chapters, including the Ryan's Retina in the 6th edition. His special interests include complex retinal detachment surgeries. Thank you all the seniors and professors for giving your time. Over to Dr. Sangeeta. Please introduce Dr. Girdhar.
Sangeeta, you need to unmute. Unmute yourself.
I'm so sorry. Good evening, everyone. Without further delay, I will invite Dr. Giridhar Anantharaman for his talk. Dr. Giridhar is a senior vitreoretinal surgeon with over 3 decades of experience. He is presently the medical director of Giridhar Eye Institute, Kochi in Kerala. He is an alumnus of Shankara Nethralaya, Chennai, and from Jaipur, Pondicherry. Please, sir, please, Dr. Giridhar, please. Dr. Girdhar, yes.
Yeah.
Yeah.
So, my presentation is seen. You can hear me?
Yes, sir, we can see.
Yes, sir, you're audible.
Okay. So the president of the West Bengal Ophthalmological Society, Dr. Aniruddha, members of the executive committee, panelists, Dr. Moona Bende, and my dear friends. I mean, it's nice to be here this evening in this webinar on 2 important topics in medical retina, that is age-related macular degeneration and diabetic macular edema. I find that most of the panelists are former Shankar Nethralaya consultants or fellows, and therefore I think most of them are trained by Dr. Moona. Anyhow, in the next 10 to 15 minutes, I will just give you an overview of age-related wet macular degeneration. Why is it not moving? Yeah. So my presentation actually will look into some of the key clinical diagnostic features, because I was told that the audience is a mix of general ophthalmologists, postgraduate students, and retina specialists. Classification based on multimodal imaging, current trends in management, and a short summary. So I think it's important for us to, I would appreciate that all these people go into mute, because there's a lot of noise background. So it's very important to make a very early diagnosis of wet AMD. And therefore, one need to know some of the very key clinical features. So this is
mute.
And basically you can see a lot of drusenoid changes in the macula. You can see some fluid in the macula here. And you can see this large hemorrhage, and this is a deep hemorrhage. You can see the retinal vessel coursing over it. Therefore, this is a subretinal hemorrhage. Therefore, this is a very classic picture of a wet age-related macular degeneration. And basically where you find the drusenoid changes, presence of fluid, and also presence of hemorrhages in the deeper layers. So this is a very classic presentation. There's another clinical picture where you can see this very grayish membrane here. This is actually the neovascular complex, and very adjacent to that, you can see a reddish color. This is the deep hemorrhage, and surrounding that, you can see some fluid, and also in distant here, you can see these drusenoid changes. Therefore, these are very characteristic clinical picture, and this probably is a very early stage of the disease. And if we catch these patients at an early stage, then treatment is more effective. Patients can also be misdiagnosed. When you see these sort of exudates, sometimes, some of these patients are misdiagnosed as vascular occlusion. But when you see these photograph very carefully, you can see again these hemorrhages, which are much larger than what we normally see in a vascular retinopathy. And again, you can see these hemorrhages are deeper, and you can see the retinal vessel coursing over it. Again, a very diagnostic picture of wet AMD. How do we classify age-related macular degeneration? A very simple classification is into three types: type 1, type 2, and type 3. Now, this is a patient with a type 1 choroidal neovascular membrane. If you see the clinical picture, this can be misdiagnosed as a central serous chorioretinopathy. Actually, there is a lot of fluid here in the macula. But if you see, and also when you see carefully, you can see some drusenoid changes also in the macula. This is a patient about 62 years old. OCT is very diagnostic in some of these cases, and basically you can see the serous macular detachment, and what is more important is the elevated pigment epithelial detachment, and this is the underlying Bruch's membrane. Therefore, this is very characteristic. When you see this, this is the neovascular complex is growing between the Bruch's membrane and the retinal pigment epithelium. That is characteristic of the type 1 choroidal neovascular membrane. And when you see this hyperreflective area between these two shadows, it is very, very diagnostic of a type 1 choroidal neovascular membrane. If you do the invasive angiography, this is the fluorescein angiography, and this is the indocyanine green angiography, you can see the network of vessels corresponding to that small elevation of the retinal pigment epithelium, which is more evident here. You can see this network of vessels with very early aneurysmal dilatation, but then mostly it's a type 1 neovascular network corresponding to that irregularly elevated retinal pigment epithelium. This is a picture of a patient with a type 2 membrane. Now you can see in a type 2, you see all the classic features. You can see the hemorrhage, you can see the fluid, and you can see the drusenoid changes, and also you see exudation. And in an OCT, you see a hyperreflective, very well delineated hyperreflective area on the surface of the retinal pigment epithelium with an irregularly elevated retinal pigment epithelium. But what is more important is the fusiform, well demarcated in this thing, along with the presence of an intraretinal edema, as you can see here. And sometimes you can also get subretinal fluid. So all this put together, this is a type 2 choroidal neovascular membrane. Of course, a fluorescein angiography is very diagnostic, and fluorescein angiography will show you a lacy pattern of hyperfluorescence, which increases in the late phase, corresponding to this membrane that you can see. So unlike the type 1 here, you can see the pre-RPE hyperreflective shadow, which is very diagnostic. Type 3 is otherwise known as RAP, or retinal angiomatous proliferation. Now this has got three phases. One is the intra, as described by Gas, the intraretinal phase. So this starts intraretinal, and therefore in the very early stages, you see intraretinal hemorrhages with some fluid in the retina. So this progresses from intraretinal to subretinal and then finally into the sub-RP in the later stages of the disease. So this also in the established stage has got very key diagnostic features. Now, if you see the color photography, you can see a large pigment epithelial detachment, and in the center of the pigment epithelial detachment you see this hemorrhagic changes and some fluid also. This again is very diagnostic, but then this on a clinical picture probably it's very difficult to say whether it's a type 2 or a type 3 type of a choroidal neovascular membrane. If you do the OCT, it's very diagnostic, this sort of a pigment epithelial detachment. One is you see large pigment epithelial detachments. Second is you see the PBEDs with a scallop margin. Third is that the PED may have something like a notch here, some sort of an erosion here. And this erosion actually corresponds to the neovascular network growing from the inside of the retina to the subretinal space. So these are all very, of course, this is a very diagnostic case, but very often in most cases, you may not be able to see all these features, but these pictures are very diagnostic or probably key biomarkers in OCT to diagnose a RAP. Now, if you see the ICG, again, very diagnostic. ICG actually corresponding to the PED, you see an area of hypofluorescence or hypocyanescence, and you see the small area of hypocyanescence or hypofluorescence right in the center of the pigment epithelial detachment. Now, this is where the neovascular network is. So presence of this sort of a hypofluorescence right in the center of the pigment epithelial detachment is very, very diagnostic in ICG for diagnosis of RAP. Of course, in a fluorescein angiogram also corresponding to the neovascular network, you can appreciate an area of early hyperfluorescence, which increases in size and intensity and becomes a little fussy in the late stages. But nonetheless, ICG angiography is quite diagnostic. And if you pass the OCT through this particular spot, you can see this erosion here, which I had already described to you. Explains the presence of the neovascular network growing from inside out. So it's very important to distinguish some of these features from a drusenoid pigment epithelial detachment. This is a drusenoid pigment epithelial detachment. You can see some of these PEDs can be very large, but most importantly, there are no intraretinal changes like the presence of serous macular detachment or intraretinal fluid. And this hyperreflectivity within the PED is very diagnostic of a drusenoid PED. And when you do, of course, the color photography, you can see these large soft drusens in the macula. But nonetheless, they should not be misdiagnosed as wet age-related macular degeneration and patients injected with anti-VEGF agents, which we have seen in our experience. Coming to the management of wet AMD, I thought we must dwell a little bit on the history of wet AMD management because basically this is a talk for all types of ophthalmologists. Actually, there have been certain landmarks as far as the development of the treatment is concerned. The first known treatment for subfoveal wet AMD was way back in 2000 when we had the photodynamic therapy, which received FDA approval. But unfortunately, PDT was an effective treatment to regress the neovascular network. But then there was a high incidence of recurrence and many not so improvement of vision, and loss of vision also was quite frequent. So for the landmark development was the development of the anti-VEGF agents. The first drug that came into use was pegaptemic, but more important are the development of ranibizumab and bevacizumab. Ranibizumab received in 2006. Therefore, it's been about 14 to 15 years that we have been using anti-VEGF agents in our practice. And therefore, we have a lot of experience regarding the behavior of these diseases, the outcomes, etc. And we have a lot of literature available today, which has a lot in improving the way we manage some of these patients. I feel the first report of the off-label use of the bevacizumab again is a landmark development. I'm not going into many of the randomized trials, but I personally feel that people who are practicing medical retina should have some overview of some of the very important trials. I always tell some of these postgraduates and also people who come for training that you should read some of these papers because that tells you how to talk to your patients. Because unless you talk to your patients properly, the patients are not going to come back. So there are two important trials initially, the Anchor and the Marina, one looking into the PDT versus the ranibizumab, and the other one looking into ranibizumab in 2 doses with sham. And most important take-home messages in the early picture was for the first time we had patients improving in visual acuity when 1/3 of the patients, or at least 1/4 of the patients, showed an improvement in visual acuity of 15 or more letters with monthly injection of anti-VEGF agents. So this is a very landmark photograph, which probably would have been shown in many, many meetings across the world many, many times, where we can see the curve here, the improvement in visual acuity with the anti-VEGF agents, and what is the natural cause of the disease. Actually, these trials also tell us about the natural cause. What happens? We need to tell our patients, when the patient asks, will I improve? What we need to tell them is what happens if you don't treat, because when you don't treat, there's a natural decay, and this decay is quite fast. You can see within 2 years, there is nearly 70% loss of visual acuity. I feel this important development in ophthalmology, in retinal practice is very, very important. And I think many of you as medical retina specialists read this contribution by Philip Rosenfield as to how he developed intravitreal ranibizumab. This was first used, of course, as you're all aware, for colorectal cancer, and he first used it intravenously for the treatment of wet AMD before he got a permission to use it intravitreally. And that was a landmark development because it made this treatment accessible to the common man, especially in a developing country like India. There are three other important trials. The importance of the CAT trial is this was one of the randomized trials that looked into PRN regimen. The PRN regimen was compared with monthly regimen, although the purpose of the trial was to see the non-inferiority and safety of bevacizumab. More importantly, I feel it looked into the PRN type of a treatment with monthly treatment with long-term follow-up of at least 2 to 5 years. And it showed that PRN treatment, although even if it is done very systematically, does not give us the same visual acuity improvement as compared to monthly treatment. And this has been true with most of the trials which compared PRN with monthly treatment. Therefore, the 5-year results of the CAT trial is again a very important landmark because it gives us certain important messages. This is a report where they recall patients from the initial trial after completion of 2 years, out of which 914 patients were called. There are 3 important messages I think I would like to give from this. One is that 50% of the patients at the end of 5 to 5.5 years still maintained a visual acuity of 20/40 or better, which we have to tell our patients. But more importantly is that at the end of 5 years also, 83% of the patients had fluid in the retina, meaning thereby this is a chronic disease requiring long-term treatment and long-term follow-up. The development of aflibercept is very important because I'm just highlighting this because now we have started using aflibercept more and more in our practice across India because of the availability of the drug and also some schemes that are available. Now, what aflibercept, the VIEW trial did was it looked into extended treatment. That is, for the first time, we had a randomized trial or one of the early trials where there were a large number of patients looked into a treat and extend form of a regimen. Now, in the VIEW trial, actually, although initially in the 52-month results, they looked into monthly and 2-monthly treatment of with aflibercept. In the latter part of the trial, they looked into extended treatment, that is extending up to 12 weeks with a cap at 12 weeks. Therefore, the long-term results of the extension trial showed that even though there was an extension up to 12 weeks, if necessary, with a cap at 12 weeks, that is what we mean by cap is at 12 weeks, even if the macula is dry, an injection is given. So 8 to 12 weeks extension was given as far as the treatment is concerned, and that did not have any deleterious effects on the results compared to the first 56 weeks of treatment. Therefore, for the first time, we got evidence that treat and extend or with aflibercept probably is a good form of a treatment to maintain the initial visual acuity improvement, because initial trials looked at monthly treatment, which is very difficult to follow, PRN treatment, which was effective, but unfortunately visual acuity improvement does not stay to the level of the monthly treatment. Therefore, today we have these drugs, these 4 drugs that we are using. I think in certain parts of India, they're not using bevacizumab. Also in South India, although in South India, we still use this quite extensively. So how do we translate the early trials into medical practice? So we have what is known as an initial loading dose where we give monthly injections so that the macula gets dry. And subsequently, we have a very stringent follow-up and enter what is known as the maintenance phase of treatment. Patient education, patient counseling, understanding the economic impact of treatment, all are very, very important when we deal with these. We want these patients to come back to us on a long-term follow-up. One of the reasons in many of the meetings, some of the things which I've heard is that they keep telling the patients don't come back, patients don't come back. It's true that patients keep shifting from one doctor to the other, but one of the reasons I feel is because we don't give good communication to the patients. So this is how we start the treatment. You can see this picture here. On a monthly basis, we are treating the patient 1, 2, 3, and finally the macula is dry. So we achieve a dry macula, and most of the cases probably initially need up to 2 to 3 injections to achieve this. And once you have reached that particular thing, next is a maintenance phase. In a maintenance phase, you can treat the patient on a monthly basis, bi-monthly or quarterly, or a PRN and a treat and extend. As you're all aware, monthly treatment is not possible. And there are studies that have looked into quarterly treatment, etc., with ranibizumab and bevacizumab with very poor results. Probably the aflibercept can be used on an 8-weekly interval treatment, but the other drugs have to be used on a monthly treatment. Therefore, what is mostly practiced in our country is what we call as a pro re nata treatment, where we treat as and when needed. Treat and extend is a very good method for certain types of patients, but it's quite uncommon in India. Some of us do practice it in some of our patients, which I will highlight later. So what exactly is a PRN treatment, I'll come to later. It's very important that how we follow up these patients after the initial loading dose. I personally feel that they should be called on a monthly basis if possible. If the patient is prepared to come, I feel for the next 3 to 4 months at least, we have to call them on a monthly basis, because the incidence of recurrence is very high. And if you call the patient, initially, actually, when I started many years ago, after the loading dose, I used to ask them to come after 3 months. But then I realized that most of them come back with a very significant recurrence. So once they lose vision, they never regain the original vision. Therefore, initially, after the loading dose, I would say that you must come on a monthly basis for a couple of months to see the behavior of the disease. And the recurrence is not coming back that fast. Probably you can slowly extend it into a quarterly basis. So I will just highlight some of a few cases here on PRN and also the treat and extend. So this is my first case here. This is a patient with about 5.5 years follow-up. I've shown this case in other meetings also. Now this is a patient here with good visual acuity. You can see hemorrhage, you can see drusen, you can see some fluid, you can see, so for this is a very good case of a wet age-related macular degeneration with a fibrovascular pigment epithelial detachment. He received the loading dose, and with loading dose, surprisingly, there was even a collapse of the pigment epithelial detachment, and the visual acuity also improved significantly. Subsequently, he was followed up on a very regular basis. You can see here the first injection was given after a couple of months. So he was having about 4 months gap between after the loading dose to get the next injection. And he was getting about every 3 to 4 months, he was getting an injection, and his visual acuity continued to be very good at 6.7, 7.5 or 7. However, somewhere 2 years after the treatment, the patient was lost for treatment for about 4.5 to 5 months. And there was a dramatic decrease in the visual acuity from 6.9 to 6.18. And you can see here, there is a lot of intraretinal fluid. In this particular case, I'm showing you, as you see the features, it's only IRF with pigment epithelial detachment. There is no subretinal fluid at all. He was again treated, and fortunately, his visual acuity improved. But again, in the course of the treatment, in the third year, again, he was lost for follow-up for a couple of months, and his visual acuity dramatically fell. And what I would like to tell you is that at this point of time, his visual acuity did improve, but it did not come to 6/24. It's very important for us to study the OCT. You can see here, the outer retinal bands are completely gone. You can see this picture here. You can see the outer retinal bands are still there. It's very effectively, so you can see the ellipsoid layer. You can see the external limiting membrane. But then down the line, as the vision acuity went down, there has been significant structural damage. And you can see here, that's the reason why the visual acuity has not improved. So he has been treated on a very regular basis subsequently with a very regular follow-up on a PRN basis. And after 5 years of follow-up, he has a visual acuity of 6/24, and he is still under our treatment at this moment of time with more or less the same visual acuity. This is the second case I would like to show you. This is a one-eyed patient. The other eye has got a scar. He has again been under our treatment for nearly about 6 years. And you can see here, initially, the clinical picture is slightly different. It is mainly a serous macular detachment with a slight defective vision. And you can see the slight irregular, something like a type 1 choroidal neovascular membrane that I explained to you earlier. He was also treated on a PRN basis initially with ranibizumab. He was doing extremely well. But 1.5 years after the treatment, he developed developed a poor response to ranibizumab. There was no response also in spite of 5 doses. At that period of time, there was very little choice in treatment. And in patients who are one-eyed, I'm usually very hesitant to give bevacizumab. And that's why I gave 5 doses before really labeling him as a poor responder. I shifted him to bevacizumab, but again with bevacizumab, there was not any good response. So I was forced to come back to Axentrix in this particular patient with, again, very poor vision. And what I would like to appreciate in this particular case is that the slow increase in the size of the neovascular network. You can see here the irregularity of the retinal pigment epithelium here, and you can see the irregularity of the retinal pigment epithelium here. The neovascular network is slowly growing and there is very poor response. At that point of time, I switched him to aflibercept. I convinced the patient, although it was so expensive, he was not a very well-to-do patient, I convinced him that there's no other choice. And fortunately, with 1 shot of aflibercept, there was a significant improvement. The macula was dry, and more importantly, the neovascular network showed significant regression on OCT. Now he is on a regular PRN-based treatment with Eylea for the last 2 years now. His visual acuity even now is about 6/9. He's doing extremely well, responding quite well to Eylea. So this is just a case to, I've shown you 2 different forms of cases just to tell you that frequent follow-ups definitely have better outcomes. Loss to follow-up at times does lead to bad prognosis. IRF has got, in the first case, as we had seen, has got a much worse prognosis than serous macular detachment, which was seen in the second case. And IRF results in dramatic fall in vision, as we had seen in the first case. It's important to switch at the right time. I was a little late in switching in the second case, but we need to switch much earlier than what I had suggested earlier to reduce economic impact and also the frustrated patient. And again, this is also, with a proper patient education, probably we can keep some of these patients on a long-term follow-up. What is treat and extend regimen? Treat and extend regimen actually is a different form of a treatment where we inject at each visit. For those of you who are not familiar, what we normally do is that we first get the macula dry with multiple monthly injections with the anti-VEGF agents, and subsequently it's extended by 2 weeks, but at each time we give an injection. Therefore, 6 weeks we give an injection, 8 weeks we give an injection, and then we extend it further. And when we extend it further, if there is a recurrence, at that point of time, the follow-up is shortened by 2 weeks, the patient comes earlier. And finally, we decide and titrate as to how much we can extend to give a treat and extend regimen. Therefore, the positive side of treat and extend regimen is that we are reducing the number of visits to the patient. The negative side of that is that we're going to inject at each visit. Therefore, we need to identify patients. Therefore, I feel that patients in your practice who need anti-VEGF agents on a very, very frequent basis, say 4 weeks, 6 weeks, like that, on a long-term follow-up, say 1.5 years. Therefore, first year you study the case, or the first 1.5 years, and then when you find that the need for injections is very frequent, probably you can talk to these patients and try and convince them about a treat and extend regimen to reduce the number of visits. That itself will reduce the economic impact. Therefore, this actually is a picture to show you, to a certain extent, one of my patients on a treat and extend with Eylea. Actually, this patient was receiving ranibizumab. You can see here there is every visit there is a fluid in the macula. Therefore, he was receiving practically every month or 5 weeks or something, 15 injections in 21 months. And that point of time, I suggested to him, if possible, a treat and extend with Eylea. And with Eylea, I've been able to extend it up to 10 weeks. If you extend it beyond 10 weeks, the fluid is coming back and there is a decrease in the visual acuity. Therefore, it can extend up to 10 weeks with Eylea. That makes quite a lot of difference to the patient as far as the number of visits are concerned, and actually even as far as the cost is concerned on a long-term basis. Therefore, we can identify patients where we can give the treat and extend regimen. Therefore, summarizing my talk, what I have tried to show in the last 15 to 20 minutes is to highlight some of the key features of wet AMD and management strategies as far as the treatment is concerned and in today's practice. Today, SD-OCT, I think, has become a very useful diagnostic and also prognostic biomarker as far as the treatment of wet AMD is concerned. I have not gone into many details as far as this is concerned, but I have focused on the intraretinal fluid and the subretinal fluid, which are 2 important key biomarkers as far as the treatment is concerned. Also, how to reduce treatment burden without compromising on visual outcomes. This is what we need to assess when we treat these patients on a long-term basis, as to how we can reduce the number of injections, number of visits without compromising on visual outcomes. For that, we need to develop our own strategies. And in the process of treating the patient, develop a rapport with your patients. And we also learned how to run a very efficient medical retina clinic. A good medical retina clinic will have good optometrists. The patient walks into the clinic, he has his best corrected visual acuity done, the intraocular pressure checked. He goes and gets the OCT done and then meets the retina specialist who, and if necessary, also a color photograph. I always ask sometimes for a color photograph because that is very educative to the patient. And then he comes to the retina doctor who decides the future course of action. Many patients who are educated actually learn the disease from us, and they themselves start asking us about how the OCT looks like. And last but not important, I feel in any wet AMD center or any medical retina center, it's important to have a small low vision clinic, because this is a very useful method by which you can improve the near visual acuity in some of these elderly patients whose pastime is basically reading newspapers or books. With these few words, thank you, and I hope this presentation is useful.
Thank you, sir. Thank you, sir. It was a very concise presentation on such a large topic. Can you hear me, sir?
Yeah. I can hear you. I'm sorry, I just started.
Yeah. So, sir, we can have some discussion on this topic. So I would like to ask one question. In this era of OCT, do you think that there is any role of doing angiography either at the beginning of the of starting the treatment or when there is a recurrence? So is there a role of doing angiography either both fundus fluorescein angiography and ICGA in wet AMD cases?
I think at the time,
present era,
I personally feel that at the time of diagnosis, it would be nice to do all the multimodal imaging once. I mean, that will help us to identify some of the variants like polypoidal disease and the pachychoroid spectrum, etc. Therefore, I feel that at the time of the initial diagnosis, still there is a role to do these tests. However, probably today in very elderly patients who are quite sick, and in certain situations where there are comorbid conditions, there are some contraindications, etc. With the OCT, to a large extent, we can diagnose the disease. So today, with the available OCT biomarkers, probably in most cases, we can reach a diagnosis as to what is the subtype of wet AMD, and also what are the variants like polypoidal disease, etc. There are key OCT biomarkers. Nonetheless, I feel at the time of the initial diagnosis, it will be nice to do the test so that we don't, like people, things like RAP and all, I don't think we can really tell with the OCT alone. It's very difficult. So unless we do all the imaging, it may not be possible. It helps us to educate the patients better as far as the long-term prognosis is concerned, because the diseases are rapidly progressive. They are usually bilateral in the sense that it affects the other eye very quickly within a very short period of time, within 2 years. And therefore, it's good to educate these patients accordingly.
Oh, thank you, sir. I would like to ask this question to the panelists also. Dr. Saurav Sinha, are you there?
Dr. Giridhar, sir, yeah. Can I ask a question?
Yeah.
So I'll ask you four questions at the same time. Very correlated to each other. What is your guideline? What do you follow practically for a patient with a MI, stroke, pregnancy, and what is your gap for a bilateral CNVM? I know it's more on CSME, but your personal guideline for an anti-VEGF in bilateral cases where you need to inject both the eyes simultaneously, stroke, heart attack, and the pregnancy.
As far as stroke and myocardial infarction is concerned, usually, as far as possible, I don't inject in the first 2 to 3 months. But if I have a patient and if I feel that this is a situation where, delaying will go, like for example, if it's a type 1 neovascular network, it's not a rapidly progressive disease. So even if you wait for 1.5, 2 months, it's not going to matter much. But then in a type 2 and a type 3, it's a rapidly progressive disease. So if you have a one-eyed patient, if you have a type 2 network, type 3 network, obviously, telling the patient that 3 months later you come, especially if this thing, I give a letter to the cardiologist. And if the cardiologist also says, and sometimes I talk to them over the phone and I explain to them, because most of them don't know what these things are. So basically I talk to them and this thing, and some of them say, no, it's okay, you can go ahead. There is no literature to tell that you shouldn't do it. So since it's just an outpatient procedure, you can go ahead, because they think it's a surgery, though they will say that I can't stop the anticoagulants, this, that, and all that stuff. But we are more bothered about the thromboembolic complications. So stroke and this is my management. If I have type 1, I may just ask the patient to come after a month or so. I'll say we'll just repeat the test and see whether how much it's progressing. But if it's type 2 and type 3, probably I would like to get the opinion and probably try and inject earlier if the patient is otherwise medically fit. Now, regarding bilateral disease, that's a very good question. Now, in bilateral disease, in our hospital, actually, we give anti-VEGF agents in both eyes. My patients who are having bilateral disease, they have at 1 week interval. That is, they have in one eye, and 1 week later, they just get this eye dilated and checked, and they have the injection in the other eye, and they come after about 3 weeks. That's what we are doing in our, as far as I am concerned. I think my colleagues also are doing the same thing. And then as far as the treatment is concerned, which eye to treat first, I think we have to identify which is the, suppose one eye is very advanced, very poor vision, and the prognosis is visual, and the other eye is in the very early stage, I think we should start the treatment in the eye which has got a better prognosis, rather than an eye which has got a very poor visual prognosis. The other eye has got 3/60 and a network already very advanced with some degree of fibrosis, and this eye has got about 6/12, 6/9 vision. I would start the treatment in the better eye and think of the treatment the other eye a little later. Depending, on this thing on. But in cases where both eyes are equally good vision, one eye treat, the other eye after a week. As far as AMD is concerned, DME may be a little different. Dr. Moona will probably be able to tell us. Then what was the third question, sir? Last question.
Pregnancy, sir.
Pregnancy, I have not, I have not treated wet AMD in pregnancy as yet. To my knowledge, I don't think I have come across a situation. I had pregnancy with toxoplasmic choroiditis and central serous chorioretinopathy. But wet AMD in pregnancy, I have not seen any case as of now. I don't know. I would not like to give anti-VEGF in pregnancy, actually. I don't. Yeah.
So pregnancy is absolutely, so you would like to avoid anti-VEGF.
Yeah.
Thank you. Thank you, sir. Thank you so much. Thank you.
Any questions from the panelists?
Sir, I have a question, sir. Very nice presentation, sir. Wonderful, as always. Sir, what's your take on OCTA? Which are the cases you, for AMD, you think OCTA is necessary?
I think the type 1 neovascular network is one type which is diagnosed better with OCTA. There are a lot of papers that have been published which shows that OCTA is more sensitive than the indocyanine angiography in diagnosing the neovascular network in a type 1 neovascular network. In fact, in type 1, I think now recently there's a paper about this nascent neovascular membranes in type 1 in the Rosen field that published. We have also seen quite a lot of cases, many of you would have seen silent neovascular network. So OCTA, I think, is very useful in the type 1 type of a neovascular network as far as diagnosis is concerned. Second thing is basically, I think today we can use the OCTA even in other situations like type 2 and type 3 to diagnose the disease where, you can't do a fluorescein angiography and indocyanine green angiography. And today's COVID situation, actually, many of us are a little hesitant to do some of the investigation. And if we have an Octa, I think it's a very useful investigative tool to diagnose these diseases. In myopic CNVM also, it's quite effective. I feel it's very effective to diagnose. For follow-up, actually, it's quite useful. I mean, basically, because we are able to differentiate between the mature network and the active, vessels, the ramification of the vessels in the follow-up. And probably to a certain extent, it helps us to decide the duration of visits, etc., in some of these cases.
Sir, taking this forward, sir, two things regarding PEDs and regarding subretinal fluid. So what's your take on PEDs? Do you we now have this thought process going that all PEDs are basically CNVMs, and so we need to treat them one. And SRF, how much of SRF do you tolerate, or do you tolerate SRF at all?
The thing is that, that PED again is a very good question. Actually, I was telling my colleagues that we should have one exclusive high retina discussion on PEDs. Because the reason why I'm telling you is that, for example, now I have an who is my patient. He has got quite a large fibrovascular PED. Actually, it looks like a polyp, but there is no fluid. There is no fluid. It's more of an exudative type. There's no fluid at all, but then he's having metamorphopsia. Now, actually, we were actually debating what to do. We finally gave him injections, but then the PED still remains the same after 2 or 3 injections. It's practically the same. It has not responded even a wee bit. So many PEDs don't respond to injections. Some of them respond, some of them don't respond. So the thing is that treating PEDs alone without any evidence of fluid and any evidence of intraretinal fluid, you can ask Dr. Moona also. I don't know, she's probably busy with something else. But you can ask her opinion also about this. She is also an expert. So, but about treating PEDs alone, I think basically it's a very, I feel like we can have a good discussion and debate on that. I would like a feedback from you all also. And regarding the fluid, subretinal fluid, whether we can leave it there. Now, what we normally do is that if the visual acuity is suppose a patient is coming for follow-up, if the visual acuity is the same, patient is not symptomatic, and there is very minimal fluid, 100 microns or something like that, I may tell the patient, okay, we'll just come next visit, we will decide. But one thing I would like to tell you is that most often it increases. Doesn't remain the same. It may remain the same in a few cases, but most often it increases over a period of time. So you can reduce the number of injections. PED definitely, a subretinal fluid definitely is protective in the sense that patients don't lose vision that fast. But then I don't agree that any patient with little subretinal fluid, you just leave it there. It's a very safe thing. I don't agree with that. But all said and done, fluid does create photoreceptor damage. So I think we should remove that. That message that is flowing everywhere about this fluid, discussion on fluid, that fluid is safe, fluid is safe, fluid is safe. I don't fully agree with that, because any long-term fluid is definitely detrimental to the photoreceptors. Therefore, a small amount of fluid with no decrease in visual acuity, yes, you can wait and watch. But otherwise, I would like to treat.
Thank you, sir.
I think we have time for one more question.
I have one question, please. Can I ask?
Yes, sir. Sure, sir.
Yeah, I have a question for sir that what about the RAP lesion? How is Octa effective in RAP lesion detection? And how is your intake, how is your advice about the anti-VEGF in RAP lesion?
Anti-VEGF in RAP, I think all the anti-VEGFs that we
I have a question, please.
All the anti-VEGFs are effective in RAP. Probably the
sir, that, what about the RAP lesion? How is Octa effective in RAP lesion detection? And how is your intake, how is your advice about the anti-VEGF in RAP?
Yeah, so the RAP lesions actually, basically, I think all the anti-VEGF injections are quite effective, but probably this is a disease which is rapidly progressive, and I mean, that is the need for injections is more frequent, I would say, in RAP when compared to other forms of wet age-related macular degeneration. I may probably think of aflibercept as the first line of treatment. I may think of aflibercept as the first line of treatment in RAP because basically because that is a little longer acting and probably, you know, that may be more effective. I mean, I don't have really much of evidence to tell that, but probably I may be inclined to use aflibercept in this situation.
Dr. Munna wants to make a comment. Please, madam.
Yeah. Dr. Giridhar, that was a wonderful talk. I just wanted to make a comment on the role of OCT angiogram.
Yeah.
Currently, we are using it increasingly, but with OCT angiography, it's important to realize that every vessel that you see there does not require to be treated.
Yeah.
And we always compare the blood vessels seen on OCT angiogram with fluid on the B scan.
Yeah.
If you see vessels like the quiescent vessels that you would see in a nascent AMD or intermediate or the inactive neovascular AMD, it probably just indicates that you should follow the patient at a more frequent follow-up rather than at your 6 monthly follow-ups. So using an Octa, yes, it takes a lot of learning to identify that not every blood vessel that you see requires treatment. It indicates it's there. Is it active or not? We're slowly finding out whether Octa alone will show, but the B scan is definitely helpful.
Shangita, can I ask one question?
Yeah.
Yes, sir. Sure, sir.
Yeah. Sir, do you have any role of doing PDT in these typical CNVM cases now?
No, we don't do any of these sort of cases. Only in PCV, I mean, classic PCV cases, we do PDT, combination therapy, but otherwise in other forms, no.
So if anybody has any questions, if nobody, I think we should go ahead with the next topic. Thank you, Dr. Giridhar. I will like to invite Dr. Rupak Roy to please introduce Dr. Munna Bhende and please invite her for a talk. Thank you.
Thank you, Sangeeta. It is indeed my pleasure and honor to introduce my teacher, Dr. Munna Bhende, for this management of diabetic, for this management of diabetic macular edema. Dr. Munna Bhende completed her Vitreoretina fellowship from Shankar Nethralaya, Chennai in 1994. Following that, she joined there as consultant in the Vitreoretina department. She is currently a senior consultant and deputy director VR services at Shankar Nethralaya, Chennai. I request Madam to give her talk on current management of diabetic macular edema.
Thank you, Rupak, for the introduction. When I saw the long list of panelists and I was taking my MBBS exams. So I hope I'll be able to answer the questions and do justice to the talk that you have given me. Thank you, Ophthalmic Society of West Bengal, for inviting me today. It's a pleasure. My talk will be on an outline of management of diabetic macular edema. Diabetic macular edema is the most common cause of visual impairment in patients with diabetes. About a third of patients with diabetes have diabetic retinopathy, of which about 7% diabetic macular edema. And about a little under half of them have associated visual impairment. So it is a significant cause of visual loss in patients with diabetes. Closer to home, our Extend-Regimen, which was based in Chennai, showed that evidence of retinopathy was seen in about 18% of subjects, of which about 6% had diabetic macular edema. A third of patients with diabetic retinopathy showed macular edema, most of which was non-center involving macular edema. When you approach a patient with suspected diabetic macular edema, you should know your patient first. For one, is there diabetes? Very often, we are the people who diagnose diabetes after looking at the eye. If there is diabetes, how long has the diabetes been there? Medications the patient is on, insulin, oral hypoglycemics, antihypertensives, lipid-lowering drugs, these are the commonest, along with many others that we may not really know much about. Has there been a recent change in medications? What is the systemic history? Renal, cardiovascular, lipid levels, is the patient pregnant? And also know that there are certain drugs that themselves cause macular edema. They are the thiazolidinediones, fingolimod, tamoxifen, taxanes, niacin, interferons, and prostaglandin analogs. Now, this is an example of a gentleman, a diabetic on insulin, who had a best corrected vision of 612 and 18 in the right eye, 69 and 10 in the left, was referred for anti-VEGF treatment for diabetic macular edema. However, going through his reports, the hemogram was abnormal, and on further questioning, he reported that his diabetologist had suspected multiple myeloma. Now, the clue in the OCT was the presence of bilateral neurosensory retinal detachment, which is something that we all need to know and identify. At this point in time, we referred the diabetic macular edema treatment and suggested that he be treated for the diabetes and the multiple myeloma both. 6 months later, you see the neurosensory detachment has subsided. Visual acuity, you see the near vision has now improved to N6 in both eyes. The macular edema is significantly reduced. He underwent just focal laser to extrafoveal microaneurysms and was stable after that. So the clue in this is bilateral neurosensory retinal detachment in a diabetic patient should make you suspect that there is something else in the systems that require re-evaluation. You also know if the patient has had any recent ocular surgery and what was the vision before diabetic retinopathy. Important because you need to manage patient expectations after your treatment. This is a gentleman who had laser for diabetic macular edema a month ago. He had undergone uneven IOL in both eyes 2 months earlier and was diagnosed subsequently to have cystoid macular edema in both eyes with VEGF treatment. Here you see is OCT showing bilateral cystoid macular edema. You see the infrared image showing the laser marks surrounding the fovea in both the eyes, quite intense laser marks. We suspected that probably is just having pseudophakic CME as a component. Put him on topical nepafenite 3 times a day for a month, and you see how the edema had subsided. This was the right eye, the clinical photograph showing there were circinates encroaching the fovea on the right eye. You see a few microaneurysms, faint laser marks, and the fluorescein angiogram showed leakage into the fovea and extrafoveal leaking microaneurysms. He underwent focal laser to those microaneurysms, and you see after 4 months, the hard exudates have reduced in number and vision had also cleared up. This was the left eye, again showing a few hard exudates at the macula. You see the fluorescein angiogram shows a few extrafoveal hard exudates, a little bit of macular staining at the fovea, again focal laser, and you see the hard exudates have dried up after 4 months. So it's important for us in a patient with recent cataract surgery, don't go aggressively to treat the macula. Maybe just a component of exaggerated pseudophakic CME. Now, this is an elderly lady who was a known hypertensive. She was a hypothyroid patient and dyslipidemic. She reported poor vision recovery after uneventful phacoemulsification and implantation. The fundus examination of the right was a little hazy because of asteroid hyalosis, but she had features typical of early background diabetic retinopathy and a few microaneurysms in the macula. The left eye was clearer. You see there are a few hard exudates at the macula, a couple of microaneurysms, and there was cystoid macular edema on the OCT. This was a fluorescein angiogram, which showed evidence suggestive of diabetic macular edema with cystoid. So we referred her to the physician for an opinion to rule out diabetes. The physician confirmed that she was diabetic, started her on treatment. We reviewed her a month later when blood sugar was under better control. and we found that the macular edema was the same. She underwent 2 monthly injections of ranibizumab in the left eye, and you see the foveal contour is returned to normal. However, the vision remained stable at 618 N8 and did not appear to improve further. She was extensively investigated, and cover test showed an exophoria with a 4-prism diopter base out prism test positive. And on repeat questioning, she said the left eye always had poorer vision than the right eye. So it's important to rule out conditions like anisotropia, amblyopia, as well as microtropia as a cause of limited visual recovery, especially when the anatomical results look so good, they're not to anything else. And most importantly, rule out other exudative maculopathies. So many of them can be treated with anti-VEGF agents without an obvious diagnosis. It's the long-term outcome that we're worried about. And this is a set of 4 pictures. If you look at it, the macula looks almost similar in all 4 eyes. But in the right, in the top left, if you see there are cercinates in the macula and you look carefully, there's a sclerosed vessel running here, indicating that this is a branch retinal vein occlusion causing macular edema and cercinates. Whereas in the top right, you see there is a large area of subretinal fluid. Again, how it exudates in a cercinate pattern, but rather than seeing microaneurysms or hemorrhage, you see a grayish network supranasal to the fovea with some nodular elevations, indicating that this is actually a patient of polypoidal choroidal neovascular membrane. Whereas in a diabetic, it is very rare to have only hard exudates in the macula. Usually you have hard exudates, hemorrhages in the posterior pole outside the macula as well. You can get flame-shaped hemorrhages and vascular changes. Usually this is bilateral. So an exudative maculopathy can be due to multiple causes, not only diabetes alone. Other lesions, sometimes we mistake drusen for hard exudates. It's important at the age of the patient, look at other features. This is actually a patient of occult choroidal neovascular membrane due to AMD. Diabetic patients have MACTEL. They may not have diabetic retinopathy. This is a patient with MACTEL and choroidal neovascular membrane. You see the classic retinal whitening around the foveal region. This is a patient with a RAP lesion. Again, RAP can cause hard exudates to the macula. It can cause intraretinal hemorrhages as well. But you also see a large epithelial detachment, which is not a typical feature of diabetic macular edema. And the last one, again, patient exudates the macula, but you see these orangish nodules in the papillomacular bundle and some subretinal hemorrhage. This is again a patient of PCV. So every exudative maculopathy needs to be looked at carefully before you decide it's diabetic macular edema. And all these conditions can occur in diabetics. Now, once we've established that a patient has diabetic macular edema, has he had any treatment before? What are the details of previous laser? Why was laser done? Very often, laser is used interchangeably for anything starting from YAG laser to a retinal break. So it's important to know what laser was done and for what. A detailed history of intravitreal injections, the drug that was used, the number of injections and the protocol, the subjective response of the patient after the injection, did they feel better or not? And what was the compliance to treatment? Because this is the most important thing which will determine whether the patient is resistant to your therapy or not. Now, once you see these patients, you have a choice. Do you treat them or to observe? Good for the patient may not be good for the practitioner. Protocol V has told us that if the visual acuity is 20/25 or better, and even if you have edema involving the center, there is no significant difference in vision loss at 2 years, whether you observe the patient, whether you treat the patient with laser or you treat the patient with aflibercept. And this is something that is important for us to know, especially when you have patients who may not be able to follow up or who may be high risk for injections. But if there is center involving macular edema with best corrected vision less than 20/25, you should definitely treat. Now, what do you treat with? A good rule is, what is the patient's compliance likely to be? If the patient is likely not to follow up with you, And if you have a chance of doing laser, like if you look at this patient, if there is a possibility that you can do laser, by all means go ahead. Because this patient possibly will not need to come back to you for at least 3 months against patients who need monthly anti-VEGF injections. But if the patient compliance is good, then you have an option for giving intravitreal anti-VEGF or steroids. Now, the evidence for anti-VEGFs in diabetic macular edema is strong. Anti-VEGFs give sustained visual gains that are much superior to laser. That is what has been shown in various studies, that these gains last for a long time, up to 3 years. And we know that requirement reduces after the first year, but you do need injections in the year 2 and 3. Anti-VEGFs are effective even if the treatment is delayed, which is shown by the patients who are on sham treatment. And also if patients have had laser, though the response may not be as good. You can also have a concurrent reduction in severity of diabetic retinopathy along with treatment of macular edema. Protocol J told us that anti-VEGFs can reduce the worsening of CME that occurs following PRP. And we all know that this happens. And if you have patients with PDR and DME, there's non-inferiority of anti-VEGFs alone, along with combination with PRP. But what is the most important requirement that needs to be explained to our patients is that they all need monthly follow-ups, at least for the first year. Now, which anti-VEGF to choose? Protocol T showed us that all the 3 anti-VEGF agents in use are effective in reducing macular edema in eyes with best corrected vision between 2032 by 2040. But if the vision is poorer or the macula is thicker, then aflibercept may have an edge. What are the protocols? You have monthly protocols, you have current protocols, and you have treat and extend injection protocols. And all these can lead to significant gains in vision, regardless of the protocol. We know that monthly injections give rapid, sustained, best corrected visual acuity improvement, but we know that this comes with a huge burden of visits that often patients cannot comply with. PRN treatment, which is possibly the most popular, does lead to gains in best corrected vision, but patients still require regular visits and monitoring, and the outcome may not be as good as monthly injections. A treat and extend regimen, what is being touted now by many of the companies, shows that the benefits of best corrected visual acuity may be similar to monthly and PRN regimens, but there are fewer visits and injections required. However, we do know that all patients do not behave similarly, and we know there is a possible chance of overtreatment, and diabetic macular edema may not be as predictable as AMD because of the systemic influence that is very strong. And there have been studies which are guided by visual acuity and OCT, but the long-term results are not yet awaited. Coming to steroids in DME, steroids are definitely useful in DME. They give a rapid reduction of edema, but possibly most of us would reserve steroids for patients with recalcitrant DME in most situations because of their known side effects of intraocular pressure rise. However, there are a few situations where steroids as the first line in diabetic macular edema are quite justified. Patients who are pseudophakic, patients who are scheduled for cataract surgery at the same time or in the immediate future, patients who are pregnant, patients who are high risk or unwilling for monthly anti-VEGF injections, biomarkers such as serous macular detachments or more number of hyperreflective dots, and again, inability or reluctance to have monthly injections, but this is a relative indication. And you see, this is a patient in 2009 where we gave 1 injection of triamcinolone in the right, had a large neurosensory retinal detachment and a lot of hard exudates and hemorrhages. And this is the OCT months later showing the macula is flat. You see the hard exudates have reduced and even the diabetic retinopathy is reduced to a certain extent. So there are a few benefits of steroids. and not only side effects, but it's important to use them judiciously. Now, when do we switch treatments? When do we add on combination therapy? This is always a question. The guidelines are different and each study has a different guideline. And each doctor has a different opinion. But as a rule of thumb, 5 to 6 monthly injections would be sufficient for you to decide whether your patient is responding to your treatment or not. In protocol U, which studied combination of a steroid with the anti-VEGF in cases with resistant diabetic macular edema, the cases had 3 to 4 monthly injections before they randomized and entered the study. Now, what do you choose? Steroids, laser, anti-VEGF, or both? As I mentioned earlier, steroids have a good effect. Intravitreal triamcinolone provides similar visual outcomes compared to intravitreal ranibizumab in pseudophakic patients. But what is worrisome is the clinically important risk of increased intraocular pressure, the need for glaucoma medications, and possibly the need for glaucoma surgery. But both of them, as I showed in that picture, the diabetic retinopathy scores may improve, though not as much as with ranibizumab. And combining laser with injections may reduce the burden of injections, but may not give better visual results. And this is what protocol I told us. And protocol U told us that the use of combination of dexamethasone implant again gives better atypical outcomes, but not superior visual outcomes. So this is something we have to get into perspective when we decide to add on a combination therapy. Now, protocol I of the DRCR-NET showed us that patients can respond in 4 different ways. They can have early and consistent treatment response, which is seen in, luckily for us, about half the patients, where you're able to predict the recovery. You can have early response but inconsistent, which is 15% of patients. The response may be slow and variable. At the end of 1 year, some patients may respond, some may not. And then you have the most difficult quarter, which is the non-responder, with neither response at 16 weeks nor at 1 year. Unfortunately for us, it forms about a quarter of the patients. But what is good is at the end of 3 months, you can generally predict the final response. So the better response at 3 months, the chances are patient is in the long run. There's not much response at 3 months, chances are patient is not going to do well. Now, this is a gentleman who had 6/6 and 6 in the right eye, 6/12 and 12 in the left eye. He had a few diabetic changes in the right eye, but center involving DME in the left eye. Initially was managed with laser photocoagulation, and subsequently, due to persistent, we switched him to bevacizumab. He had an initial good response to bevacizumab. You see this, the last 2 images, you see how well he responded to bevacizumab. However, his diabetic control was erratic and he lived overseas and he was finding the monthly visits for injections difficult. Though he said he could get his follow-ups there, for monetary reasons, he preferred to have the treatment in India. So after he had 6 injections of bevacizumab on a monthly basis, his vision was 6/12 and 6, and we noticed that there was a progressive increase in edema with the last 2 injections. At this point, there were 3 options rather. Do we switch to intravitreal steroid, change the anti-VEGF, or just give him a drug holiday? Because our understanding in 2015 was very different from our understanding now. And there were definitely, as I mentioned, issues with further follow-up on a monthly basis. So we gave him an intravitreal dexamethasone implant, followed him every 2 to 3 months. His intraocular pressure was maintained without medication. His best corrected vision remained 6, 9, and 6 at 11 months. And he required a repeat injection after 18 months, and he's still doing well. The final reason you would, the final treatment for a patient with diabetic macular edema is vitrectomy. And this is some benefit in patients who have demonstrable epiretinal membranes, taut posterior hyaloids, or vitreomacular traction. This gentleman had treatment in the form of laser and intravitreal anti-VEGFs for center involving diabetic macular edema. Subsequently developed vitreomacular traction in the left eye, for which he underwent vitrectomy. 2 years post-vitrectomy, you see that he has a good forefield contour, best-corrected vision, 6, 10, 6. When to stop? Inject monthly until no further reduction of macular edema is present. You may want to add focal laser, but you can follow up patients with good vision and a small cyst without causing deleterious results. And this diabetic patient who had laser for center involving diabetic macular edema subsequently had multiple intravitreal injections and gave a micropulse yellow laser. 16 months post laser, he had small cyst close to the fovea while maintaining a visual acuity of 6, and 6. Most importantly, diabetic macular edema is due to a systemic problem where you have to coordinate with the diabetologist and the nephrologist, control all systemic factors. This may answer Saurav's 4 questions to Dr. Giridhar. In case of recent vascular events, preferably avoid anti-VEGFs for 3 months. In pregnancy, preferably avoid anti-VEGFs altogether. They may be safe in the 3rd trimester, but we would prefer steroids or laser. In the presence of active infection, wait to inject, consider laser as an option if you have to. And in case of a diabetic foot, you check with the treating physician because diabetic foot is a long-term treatment and you may not be able to get rid of the infection so easily. If there is dyslipidemia, you can concurrently, but a good control of dyslipidemia gives you better treatment outcomes. And remember, patients with obstructive sleep apnea and patients on glitazones, refractory diabetic macular edema is known and you need to look for that. And more recently, we know that we need to watch for renal parameters in patients on anti-VEGF therapy. So we have guidelines from all over the world. We now have our Indian guidelines coming up as well. So this is my last slide. First thing we need to know, diabetic macular edema is not AMD. There are other options other than anti-VEGF agents, luckily. We need to know the patient as a whole, not or his OCT or his wallet. We can choose in good cases with good vision between treatment and observation. You have 3 options of treatment to start with. The treatment regimen is appropriate for the milieu, and as far as possible, we avoid bilateral simultaneous injections. Give a gap of a minimum 3 days so that if patient develops a complication, most of them would manifest it by then. But practices may vary from place to place and country to country. There is an endpoint of treatment in most patients, but we need to follow them lifelong because PDR can develop, which may be temporarily suppressed by your anti-VEGF agents. We are learning to define resistance and how to handle it. There's a selective role of vitrectomy, but what is most important is patient compliance and diabetes control. Thank you very much for inviting me and for listening. I'll stop sharing my screen right.
Thank you, madam, for an excellent presentation. I have a question for you. What is your preferred, like as you know in CNVM, we usually start the patients with 3 loading doses. Now in diabetic macular edema patients, do you follow the same protocol or you just give till the macula becomes dry and stop? Madam, you are...
Yeah. I do tell my patients because there's 3 injection, most patients know it when they come. So I usually tell them that yes, maybe 3 injections is to know whether you're responding or not. So that's how I put it. And if I see that there is no further response, then I would look at giving alternative treatment, revisiting their systemic status, etc. But I use the word 3 basically as a way of telling them at the end of 3, if it's not responded, we have to change the drug.
Right.
That's how I would use it.
Thank you, madam. Another question is, what is your opinion on Ozurdex as a first line of treatment? Do you have occasions where you have practiced Ozurdex as first line of treatment for diabetic macular edemas?
I have used it, yes. I mean, the side effects are not as bad as people say they are. And, but I would probably reserve it for patients where I'm hesitant to give anti-VEGF injections.
Okay.
Patient who is systemically not stable or something like that. Because we do know that anti-VEGF's side effects are less, visual recovery is good, but Ozurdex as primary, a very selective role. I may give it along with cataract surgery or something like that, but my first choice would still be anti-VEGF.
Okay. We have a question from Dr. Saurav Sinha. Sir, please go ahead.
At the outset, ma'am, thank you so much for inviting, for accepting the invitation. And like Rupak Roy said, you're his teacher. Ma'am is my teacher twice over, retina and MBBS anatomy. So I'm twice a student. Moving from there, I 2-3 quick questions, ma'am. One is because I think this Ozurdex, what Rupak said to push it forward, pseudophakic naive patients with diabetic macular edema, gross edema. Is it time you think with the way we change our practice, because the cost is so prohibitive, and assuming that a patient is bilateral and will need multiple injections anti-VEGF, would you feel that pseudophakic patients, bilateral patients, it's not such a bad idea to even think of starting? All of us need to change the way we think. Bilateral patients, pseudophakic, Ozurdex as a naive treatment in these patients with very high edema.
Yes, it is. It is an option, definitely. But I think it becomes, at some point in time, it becomes a matter of preference. If there is a very high edema and a lot of hard exudates, I would like a little gentle reduction in the edema.
Yeah.
So possibly that way, but definitely I think it is an option and I don't discount it at all. If systemic status is, I am a little doubtful, then I would give Ozurdex as an option. I'm quite happy giving Ozurdex, is no problem.
Ma'am, two quick questions, because you have a lot of general ophthalmologists with us. One is, if a patient presents to you with a large subfoveal plaque, hard exudates, with poor vision, with some edema far away, would you treat that eye with no PDR? Would you treat that eye with an anti-VEGF? Poor vision, large plaque.
I would probably give a try and see what happens, because whatever said and done, if there is leakage, there is a propensity for the plaque to become larger, chronic edema. If you have visible extrafoveal microaneurysms, you need not inject. If it's only a plaque, but no edema there in the center, you're perfectly justified in focal laser treatment also, because it's going to change the vision anyway.
You showed that OCT reduction on that IVTA patient,
Yeah.
one injection and thing. Do you believe in combination therapy for these patients, like doing some touch-up laser after that nice reduction?
This patient did undergo a laser subsequently, but this was the pre-anti-VEGF era.
What about now? Now, do you do any add-on lasers?
I do. I did show a couple of cases where once you see that the edema has moved away from the center, patient is around 6'9", 6'12", and you can see visible microaneurysms. Why not?
Because you and me think alike. The younger generation thinks no laser. Protocol DRC stands God's truth. No laser at all. That's why I said that.
Yeah, but like moving with the times, what I would do now, because we are fortunate we have a yellow laser in the hospital, I probably send them for yellow laser because we know that causes less of scarring. So probably that is one change I may have made in my practice, but if not, then green laser is perfectly fine. I think laser has a role to play.
Okay.
Thank you, Rupak.
We have a question from Dr. Anirudh Maiti. Please go ahead, Dr. Maiti.
Madam, is there any change in a pattern of treatment in this COVID times? Because I'm asking these questions because the patients, there's difficulty in coming very frequently. So instead of anti-VEGF, can we plan for an Ozurdex injection, and we can actually reduce the exposure and the interval of treatment?
With COVID, I'm probably looking at the use of laser more where possible. as chances are that you don't have to monitor intraocular pressure. You have less risk of complications. And you can sterilize your lenses. There is no problem. Definitely, I would think I am a little more in favor of using a little more laser if possible. But yes, and now we are calling the patient on the phone to check up if they're all right and do it. So steroid is an option, it's not that, but you do need to monitor them for intraocular pressure rise, especially if it's the first time. If you know patient is not a steroid responder, there is a possibility he will not be a steroid responder the next time. But we have had patients who have had the steroid response third or fourth injection late. So that's something we need to know.
And what about the follow-up of anti-VEGF injections? Do we call the next day, or what is your?
Well, our standard follow-up is to see the patient the next day. But now, because
during
of
this
COVID,
time, is it possible?
We are calling them up the next day. We are calling them up, explaining to them the symptoms and telling them when they need to come if there is a problem.
So is it the
possible what we
after
are
3 weeks the first visit?
Sorry?
Is there fine? The next visit, is it after 3 weeks giving anti-VEGF?
No, 4 weeks to a month.
4 weeks to a.
Unless they have, probably we explaining a little more in detail symptoms they should recognize.
Right.
And then tell.
Dr. Giridhar sir wants to come in with a comment and question. Sir, please go ahead.
Yes.
Mona, nice presentation.
Thank you, sir.
I have two questions. One is your overseas patient, which you showed, you made a comment that this was managed 2 years ago, 3 years ago, and at that time our concepts were different. Now,
Yes.
what would have been different in the management if you had seen the patient now? I mean,
So now I would have had the option of giving him aflibercept also, sir, because he was faking.
okay, right. Then number two is, how do you manage patients with predominant serous macular detachment? I mean, sometimes, we come across diabetic macular edema with predominantly SMD.
Yes, so when I see bilateral SMD, the first thing I'd look at again is their systemic status.
Hypertension.
That is the first most important thing with bilateral predominantly. We've had a couple of patients with myeloma, I showed one. A lot of them are have renal problems as well. And very often they're just getting their AccuCheck done and confirming with their doctor on the phone. So bilateral SMD, I would look at it a little differently before starting treatment.
Yeah.
And if everything is okay, yes, I do consider steroid as an option, but otherwise anti-VEGFs work as well.
You have also had some patients with coexisting CSR.
Yes, sir.
With serous macular detachment. CSR type leak.
Yes, sir.
Then another question, which comment I had is, in
Yes,
bilateral DME, I usually advise not to treat both eyes in a short gap, unlike wet AMD, because the response to treatment may not be, we can't gauge. That is, suppose now you decide on an anti-VEGF in one eye, and that is a poor responder. Then you end up treating both eyes with a poor responder. So I would normally, because DME doesn't progress that fast. So I usually give 1 or 2 shots in one eye and I see whether he's showing any response, and then I decide to treat the other eye. I mean in DME, because otherwise, you give, so for example, you give bevacizumab in this, 1 week later you are, whatever the protocol you give in the other eye, and 1.5, 2 months later you realize that this is not working in both the eyes together. So what is your opinion on that? I mean, do you think that my thoughts are correct, or?
Sir, I think that would depend on the individual case. If it's possible to postpone, fine. But I probably have very rarely used this option in patients where there is definite drop in vision and the need for bilateral treatment. Supposing I find one patient with 6/9 and a small cyst in one eye, but 6/18 and definite edema in the other, then I would not treat both eyes. And at one injection, I wouldn't worry too much about resistance.
And one question to all the panelists and the speaker. You sometimes see this cystoid blob, in the macula, just a cyst and nothing else. Now, how do you manage that? That doesn't usually respond much to injections. So you would have seen, isn't it? Just a cyst, a small cyst right in the center. Otherwise, everything looks okay. So how do you manage that? You give multiple injections or?
Dr. Sinha, please.
I make the patient give one of those simple flare or something that's what asking come by every month and keep showing the same OCT and color photo. Like you said, I love doing color photos. I ask them keep coming back till they get bored and don't come back anymore. Because I know that like exactly what he said, they won't go away. Anybody else, ma'am? Anybody else?
Can I add something to that?
Yeah.
Yes. Sometimes cysts with a good vision, you're quite justified in leaving it alone. One patient was symptomatic and I switched him to aflibercept. And I found that the response came almost 4 to 5 months later. So that kind of, initially I said, it's not working, leave it alone. And then he used to see me every 2 months, and over a period of time, the itself gradually reduced. So that's one thing I've learned, that maybe it takes time to go away. We need not go in a hurry and keep on retreating.
I have a question, madam, from the audience for you, from Dr. Vedang. He wants to ask on the role of anti-lipids before giving injections in patients with a lot of hard exudates, I presume.
Yes, I think I did address that in my in one of the slides. Basically, when you have a large amount of hard exudates, you do want to rule out nephropathy and dyslipidemia. And there is no harm getting a lipid profile done. But most of the time, there may not be much justification in waiting for the lipids to come down. You can treat the patient. The response is definitely better. The lipid profile is good. But there's probably no need, unless there's really a systemically serious problem, to wait. You can treat it and edema does come. That's what evidence tells us, that there is no absolute need to wait, hold on treatment just for that.
I have a question.
Not going to reduce overnight.
Okay, madam. I have a question from Dr. Debdulal. He wants to ask a question. Dr. Debdulal, please go ahead.
Ma'am, taking this question forward, do you advise atorvastatin or any statins or similar drugs to your patients?
I don't prescribe anything for systemic medication. We are fortunate to have good diabetic hospitals where we share a very healthy working relationship. So usually we would send them to one of them, and if you find, if it's a local patient, I tend to call up the doctor and speak to them myself if I feel there's something needs to be done. But on my own, no.
We have a question from Dr. Sudipto. Sudipto, please go ahead.
Ma'am, nice presentation. Ma'am, regarding that laser, because we don't have any obvious proper guideline in doing laser except that protocol I about prompt and deferred laser. So how do you time your laser in central involving DME, and whether you do more than focal to MAs now, and whether there is a difference between this yellow and our normal conventional green laser?
A center involving DME, probably I would consider laser as a first line of treatment if the patient is systemically not very stable. I would definitely look again and see if I can do laser, because we definitely manage these patients in the past quite well. Laser is not as bad as it's made out to be. So, but now probably because we know that the results of anti-VEGF is good, once we find that the edema is moved away to the extrafoveal space and you can see that there are visible microaneurysms, most importantly, large microaneurysms. Sometimes in a resistant case, I didn't show any pictures, but sometimes you see these very large microaneurysms that almost look like macroaneurysms, except they're in the capillary bed and not attached to the retinal vessels. Now the leakage doesn't stop with anti-VEGF injections, neither does it stop with steroids. So those patients, if you can identify those lesions, then I would definitely do laser. If you don't have yellow laser, green laser is fine. Avoid a very small spot size because it can rupture the vessels. You can use your standard 100 micron spot and treat.
Thank you.
Thank you. I have a question from Dr. Kumar Saurav about, are you doing less FS for DAB now as when OCT angiography has come, or its indication remains the same? What is your opinion on FA in fundus fluorescein angiography in your DME practice? Madam, are you there?
Sorry, if I feel clinically that the patient is likely to benefit with laser treatment, I would prefer to do a fluorescein angiogram and treat. But if you have a patient who comes without an attendant, patient who is otherwise, you think that the renal parameters are a little abnormal, and you get a good clinical photograph and manually segment your OCT angiogram, you're able to rule out macular disease, then you can, on certain occasion, treat these patients without a fluorescein angiogram. Right now, we are doing less fluorescein angiogram because of COVID. We want to minimize patient time and any invasive procedure in the OPD.
Okay. We have a question, madam, from Dr. Shantanu Mandal. Is steroid, what about intravitreal triamcinolone? How often do you use it in your practice, especially for people who cannot afford? Is it still an option, or it's really done away with?
It is an option, definitely. 2 milligrams triamcinolone, not 4. 2 is safer.
Thank you, madam. Thank you very much for answering all our questions. We had a wonderful session. We'll like to come to an end of this program now. I'll just request Dr. Kumar Saurav to give a vote of thanks. Dr. Saurav, you have to unmute yourself.
Hello, good evening. Thank you, everybody. It was a nice session conducted by OSWB, and we thank our guest speaker, Dr. Giridhar and Dr. Muna Bende, for gracing the occasion. We like to thank the chairpersons, Dr. Kajal Prasad Ghosh and Dr. Professor Asim Ghosh, and all the panelists who presided over this meeting. Moderators, Dr. Rupak Roy, Dr. Vedang Shah, and Dr. Sangeeta Rai, to the least, because they moderated the sessions very well. Thank you, Ozodex and Allergan for sponsoring this program. Thank you.
Thank you. And happy Independence Day.
Happy Independence Day, sir. Thank you.
Can we take a screenshot of this?
I had a nice time.
Rupak, unmute yourself.
Before we end, can you just have a few words from our chairperson, Dr. Asim Ghosh and Dr. Kajal Prasad Ghosh, sir, please. Dr. Asim Ghosh, sir, please.
Sir, thank you for OSWB inviting as a chairperson here to be present. Sir, I also noting thanks to Dr. Giridhar and also Dr. Muna. Muna, probably we are very happy that you are training all of my RIO PGTs, those who are sitting here. Do you remember? Do you are you listening? Hello.
Yes.
Hello.
Sir. Yes, I am listening.
Rupak, Saurabh, all our students of RIO. Now also the many students of RIO are being trained there under your guidance. And also you are happy with your presentation. All presentation with some valuable talks will highlight their knowledge of the present PGTs of RIO. Please accept our invitation from RIO if we are getting chance afterwards. Thank you very much. Dr. Giridhari sir, also I will just thank you with some pleasure. Please sir, if you get chance, we have to invite you and then come here to speak, give some speech for our PCTs. Thank you very much.
Dr. Ghosh, sir, please.
Thank you to both of them for this comprehensive speech on these two burning problems of ophthalmology, diabetic macular edema and age-related macular degeneration. I think everyone who are present over here were really enriched by that talk. And future WSWB will again be expecting them to come in such webinar and give us their expert knowledge on this subject. Thank you. Thank you.
Thank you very much and happy Independence Day to all. Goodbye and good night.
Thank you.
Thank you.
Thank you.
Nice
Goodbye,
seeing
good
all
night.
of you.
Thank you.